I have an attending who likes to say that in emergency medicine, we're sensitivity people, not specificity people. And that's really affected how I navigate work, but almost more importantly, how I have conversations with patients and talk about return precautions, patient safety, and stuff like that. So here's an example. Let's say you have a 40-year-old female, recent travel, long airplane, coming in with unilateral leg swelling and shortness of breath. They're tachycardic, they're hypoxic, they have a cancer history, they're on oral anti-contraceptives. These are all PE things, right? There are other things that can cause shortness of breath, but right there in that moment, being a sensitivity person, I want to make sure they don't have a pulmonary embolism. And there are varying levels of ways that you can approach that situation. You can, based off clinical suspicion, just go get a PE scan. You can get a D-dimer if you want. You can do an echo, see if there's signs of right heart strain on your ultrasound. Is there 60-60 sign? Is there a McConnell sign? Is there RV strain? Things like that. But I feel now in residency, that's the easy part, right? Doing the workup, you have enough buzzwords in your head where you raise a clinical suspicion. The hard part at times is knowing that it's none of the things that's going to directly harm a patient and reassuring the patient that they can be safely discharged home. You can go to a patient and say, hey, given your history, here are the big things that I'm worried about. You come in, shortness of breath, your heart rate's very fast, your oxygen was low, and I'm worried about a blood clot. You don't have it for these reasons. You get worried about infectious things like pneumonia. You don't have it for these reasons. And maybe pulmonary embolism is a bad example, but with any kind of chief complaint, chest pain, belly pain, shortness of breath, they're very big things that can be acutely life-threatening. I say out loud the things that I was worried about, the reason why I'm not worried about them anymore, and the reasons why I think it's safe to go home. I say everything out loud. And as a medical student, I wish I started this earlier, because then I would be able to say my differential diagnosis out loud to the patient as like an exercise. Like bronchitis, URI, pneumonia, pneumothorax, pleural effusion, malignant pleural effusion, mediastinal mass, pericardial effusion, heart failure, PE, whatever. I found that it's a lot easier to reassure patients if you just say all those things out loud and say why they don't have those things. Because oftentimes providers or doctors or whomever just kind of disappears for 4 to 12 hours given our ED wait times, and then they come back and say, hey, everything's fine, have a nice life, you're discharged, right? Without explaining any of those things. And it's just kind of the decent thing to do, I think, to say the things out loud to your patient, because then they don't have to take your word for anything, or they don't have to assume anything. You're just saying those things out loud. So it's something I wish I did earlier that I'm glad I'm getting into a habit now and kind of going through that in front of patients, especially with learners and med students around.